Today I have a very interesting case. This patient has had cataract surgery more than 30 years ago, and he has a silicone lens in his eye, and then he developed a retinal detachment, macular pucker, had surgery, had silicone oil put in, and then the silicone oil was removed, but then the silicone was plastered to the back of his lens, and so now he can't see. We don't know his vision potential. His lens is tilted, his pupil doesn't dilate well, and so today we're going to do an IOL exchange and replace it with a new lens implant. Because of retinal detachment, we don't know how much the retina was affected from that detachment. And so we're just hoping for the best. It's going to be a tough case, but we are prepared, ready to go, and hopefully we can help this patient see better again.
Before getting started, my patient generously gifted me a pair of shoes to wear for the operation. Having waited years for this surgery, he wanted me dripping in style and to start the day on the right foot, insisting the shoes didn't touch the floor until we walked into the operating room. Here we are at the start of the case. There's a decentered optic. At this point, we didn't know what kind of IOL it was. We knew it was a silicone IOL. And as you can see, there's silicone oil plastered on the posterior surface of the IOL and silicone oil in the anterior chamber. I had assumed this IOL was probably the SI30. It turned out to be an SI18 lens, which came out in about 1989. There's no posterior capsule, so either there was a previous capsule break or a large YAG capsulotomy. The plan is to perform the IOL exchange without dropping this old IOL, lyse any synechiae and adhesions, perform thorough anterior vitrectomy. Even though the eye was vitrectomized, we just want to make sure the area that we're manipulating with the old lens and new lens, that there's no vitreous there. And we're going to scleral fixate the IOL if there is insufficient support for a sulcus IOL. This is intracameral anesthetic with epinephrine. It's helping wash out the silicone oil in the anterior chamber. One thing I'm not sure is what's holding this IOL in place. Is there peripheral capsule support, or is the IOL being held by adhesions? When I separate and lyse these adhesions, will the IOL want to drop? And so I'm going to be very careful as I manipulate this IOL. I put some viscoelastic to keep the AC formed and to protect the corneal endothelium. In this case, there will actually be 10 total incisions, each with a specific purpose. These are the first two paracenteses that I make. I use a Kugeln hook to explore and assess the situation. The IOL is decentered significantly infranasally. When I try to move the iris here, the entire IOL complex moves with it. Looks like there's a lot of iris fibrosis temporally, a thick band of fibrosis and iris fusion, and significant fibrosis around the haptics. I can't seem to free the iris from the underlying IOL bag complex temporally. I don't want to use iris hooks just yet. I'm going to use viscoelastic to try to break any adhesions more peripherally underneath the iris, and I approach from both paracenteses. And then as I do this side, I try to buttonhole the optic anteriorly, and the iris is now going to act like a shelf, preventing the IOL from falling just as I loosen these haptics. Now that I have the reverse optic captured inside the pupil, I feel much more comfortable trying to rotate or manipulate the haptics and freeing up the lens completely. So I use viscoelastic near the haptics to try to see if I can free it up at all. I then use a Sinskey hook to see if I can rotate the haptics out from their fibrotic capsule. And I'm trying to be very careful. I'm being mindful of the iris root because I don't want to induce an iridodialysis during these maneuvers. I try to go from both sides to see if one comes out more easily, and the superior one is coming out. It's much looser than the inferior one. And that inferior one, the haptic tip is closer to the area of temporal fibrosis. I think a bimanual technique would help me more at this point. So now that I loosened it up as much as I could, I'm going to create my main incision about 3 millimeters, and I'm going to try to get a good grasp of the optic. I lift the optic a little bit just to get it away from the iris as I try to grasp it with the MST IOL forceps. Now this is silicone, so it's a little bit harder to grasp, and I'm going to use the MST IOL cutters to try to bisect the lens. These scissors are not serrated, so every time I try to cut this IOL, you can see it just slide away from the scissors. And my IOL graspers aren't really helping much either because I don't have great purchase on the IOL, just the tips are holding the IOL. And so the IOL rotates around the IOL forceps as I try to cut it. And I'm slowly advancing my scissors, getting a little bit better, but it's quite annoying. And so I'm going to use my Kugeln hook just to push the IOL into the forceps better. So now instead of just having 1 millimeter of the IOL in the forceps, I have 2 millimeters. I have full grasp of it, and it does make it easier, but still this silicone is super slippery, and with these scissors, it's frustrating trying to cut this IOL. But eventually, I get it bisected in half. There are some new scissors coming out by MST. I think they're called the Fram Airs scissors, and they're serrated, so that will be really good for silicone lenses. Of course, they will work well for acrylic IOLs as well. So if you're looking for some new IOL cutters, ask MST for the Fram Airs scissors. And Epsilon is making a really nice grasper, serrated grasper. It's huge to get really great purchase on silicone lenses. Dr. Shannon Wong featured them in one of his recent videos where he was taken out at LAL. Look at this IOL. It's an SI18 IOL implanted about 35 plus years ago. It's an asymmetrical design with one side, one haptic having a looped tip. Interestingly, I had another patient whose wife worked in ophthalmology 30 to 40 years ago, and they brought me this relic into my office. This is when ophthalmologists started doing single stitch cataract surgery, and they were bragging about it because it was so modern. And there's this lens card, which is this lens. This is the SI18 Phacoflex 1 lens. So here we're removing the second half of the lens. I'm just going to inspect underneath the iris here to see what we got working with. And there's a huge Sommerings ring there. And this iris is fused underneath with some scar tissue. And even though vitrectomy was performed and silicone oil was put in and removed, because we're going to be doing a lot of maneuvers in the area just posterior to the iris, I'm going to perform thorough anterior vitrectomy. When I am injecting viscoelastic here, I'm seeing that this shelf of peripheral capsule is sinking deep posteriorly. So there's not a good shelf to put a sulcus IOL. These are my incisions for my iris hooks. I go about 1 millimeter posterior to the limbus. A partial entry is enough since the iris hooks are very small. And I place all the hooks in the anterior chamber. I don't engage the hooks immediately. I just put them in, and then after they're in the eye, then I can engage the iris. It just makes it more efficient. The only disadvantage of making all your incisions before you place the hooks is that sometimes it's hard to find where you made the incisions, so definitely make a mental note on where they are. All right, and I turn the hooks, engage the iris. I don't want to place too much tension on the pupil border. Sometimes if you apply too much tension initially, it'll make it a little bit harder for the opposing iris hook to be engaged. This is the area with a lot of fibrosis in that thick fibrotic band. I'm applying just enough tension to give me an adequate view. And again, I'm using a lot of viscoelastic here. I'm just trying to separate the iris tissue from the underlying fibrotic tissue. And this is fused. Like this fibrotic membrane here has to be cut away or eaten with the vitrector. But there's no shelf temporally to put an IOL in the sulcus. And the area where there is a shelf, it's deepening a lot from the viscoelastic. So I'm going to increase my tension a little bit in a stepwise fashion. I don't like to put all the tension at once. I'm seeing how much the pupil can tolerate. And look at this one. When I pull it, it just unhooks. There's too much fibrosis here. And so when I put a lot of tension, the hook just slipped off. Here I'm placing an incision for my AC maintainer. I will be using a 23 gauge Lewicki AC maintainer. There's the AC maintainer. And now I'm going to place a trocar 3.5 millimeters from the limbus. You go in beveled so that there's a long groove within the sclera. And once you get to the cannula, then you turn and go into the eye. And you'll see the trocar have an angulation to it. That confirms you have a good tunnel and bevel. And now I'm just doing anterior vitrectomy. Even though this eye is pre-vitrectomized, I want to make sure the retropupillary space is nice and clean. And I'm just slowly going more and more peripheral. I'm trying to eat any of the scar tissue. Here's this thick fibrotic band I want to separate. And I'm going to try to move as much of this fibrotic tissue as possible. And after doing a lot of anterior vitrectomy, then I switch modes from cut IA to IA cut. There's that large Sommerings ring that I'll remove later. There's a lot of debris as I remove these fibrotic bands. One thing you got to keep in mind is that when you disturb this tissue and now you have debris floating around the eye, all this fibrotic tissue was sitting there dormant for so many years, and now that we're breaking it up, we really want to take our time trying to clean out this floating debris as much as possible. That can cause significant inflammation in the post-op period. And so I switch from cut IA to IA cut to try to aspirate as much of it as possible. I'm forwarding through some of it, but here it's looking really clean. When removing the cutter from the trocar, you don't want to be cutting so you don't cut the valve within the trocar. And so now I'm going to release some tension on the iris hooks. I want a larger shelf for the IOL prior to Yamane. So I'm going to inject more viscoelastic to protect the corneal endothelium because I removed most of it with the vitrectomy. I'm removing this air bubble just to get out of the way. And next I place my marks. First, limbal marks exactly 180 degrees away from each other. And then I use a caliper to indent the sclera 2.5 millimeters back from the limbus. I do this on each side. I'm tempted to get that fixed caliper from Epsilon with 2.5 millimeter on one side and 2.0 millimeter on the other. I'm noticing the conjunctiva balloon up there on the left, so I snip the conjunctiva so that it doesn't continuously expand. Then I place marks 2 millimeters adjacent to the more posterior mark. I place some ink from the cannula on the area where I want to enter the sclera. I dry the bed before placing my mark to minimize ink bleeding, but sometimes there's still a little bit of bleeding of that ink. Now I'm placing a paracentesis opposite to my main incision because I'm going to perform the Kim-modified Yamane technique. This is where you exteriorize the leading haptic and cannulize the trailing haptic first. That's a 25 gauge needle that I'm using to guide the leading haptic. My surgical tech is rotating the plunger, and then once I get the leading haptic out, I take over and I advance the lens in the anterior chamber, keeping that leading haptic out. And I'm going to thread the trailing haptic first. This IOL is an AR40 IOL from J&J. It's a hydrophobic acrylic IOL. So this is a 30 gauge thin-walled needle by TSK. I go in 2 millimeters and then I turn in, entering the eye. And then I'll use microforceps to grasp the trailing haptic about 3 millimeters from the tip. So that way I just have to grasp it once. Just go in the eye, 3 millimeters from the tip. And now I'm careful as I dock the haptic in the needle to prevent a kink. And I'm really just holding the haptic in the same position and adjusting the angle of the needle to make sure that it's appropriate so that trailing haptic does not kink. The AC maintainer came out, but that's okay. I'll put it back. Next, I'm going to remove the syringe from the needle. And now I'm going to let it sit there. I advance the leading haptic further in the eye to facilitate me grasping the haptic 3 millimeters from the tip. Now I'm going to pass my 30 gauge TSK thin-walled needle, 2 millimeters in the sclera before I dip down. I need some counter traction for my needle pass, so I will grasp the incision. Centering the IOL, the most critical aspect of centering it is making sure that the part of the sclera you first entered with the needles are 180 degrees apart and centered on the cornea. The tunnel length and angle will determine tilt, but where those haptic bulbs are eventually going to sit, that is going to be what you want, 180 degrees apart, and a line from those tips should bisect the center of the eye. So what I'm referring to here is the point on the right here where the needle enters and the point on the left where the needle enters. This determines lens centration. Tunnel length, angle of attack, and symmetrical placement away from the limbus determines lens tilt. I remove one haptic completely and cauterize the tip. The other one's just hanging on the needle. That's not exactly intentional, but it's holding it there, and so that's fine. And I'm going to cauterize this tip just a little bit. I do want it to be buried in the sclera, and that's enough. And then I'll remove the second needle, grasp the haptic, and then cauterize the tip. And both of these haptics were flat against the sclera. They were not pointing up like a flagpole. There's a flagpole sign, and that usually indicates that you didn't have a scleral tunnel that was long enough. So one haptic is already mostly advanced. You see the optic towards the left, but as soon as I advance the haptic on the left side of the screen, you're going to see the IOL center. It's not fully advanced yet, but I'm going to advance it right now. There we go. See, now we got really nice centration. Look at that light reflex on the lens. It's right in the middle. That's great centration. And I just want to make sure that that haptic is buried. So I'm just inspecting that area, making sure it's fully advanced so it doesn't slide out and erode through the conj. Now that the lens is in position, there's some debris behind the lens, so I'm going to perform more anterior vitrectomy to try to clean up as much of it as possible. This debris is very inflammatory, and so you really want to clean as much of it as possible. Some of this material, along with some of the viscoelastic, inevitably falls posteriorly towards the posterior vitreous cavity and to the retina. And so in these cases, you can expect some inflammation after surgery and post-op IOP spikes. Next, I'm going after this large Sommerings ring. It's huge. Removing Sommerings rings is pretty annoying. It doesn't come out so easily. It's a combination of burping the incision, placing viscoelastic behind it, and then burping it again to try to remove that material. And it fractures pretty easily. You don't want it to fall back as well. Eventually, I'm able to burp it out. This is actually triamcinolone. I don't have a reason to think there's vitreous, but it's overly dilute, so I think they put a gallon of BSS with the triamcinolone. It's a bit more visible with the surgical microscope than what shows in the video, so I didn't feel the need to replace it. After completing the vitrectomy, I remove all the iris hooks. You can see how stiff and fibrous the iris is on the lower left. After removing the hook, there is no movement to it. And at this point, there's 10 total incisions. There's 4 for the iris hooks, AC maintainer, the nasal paracentesis for the leading haptic for the Kim modified technique, 2 paracenteses that I initially created, a main incision, and the trocar sclerotomy. After removing the iris hooks, this part of the iris is so fibrotic and peripheral. I'm trying to unroll it, trying to bring it centrally, seeing if it'll stay. But see how irregular that is? There's so much fibrosis there. It's highly irregular, not round, and it's likely to stay peripherally due to all the fibrosis. And so I'm going to perform a pupilloplasty. I pass a tenoproline suture on a CIF4 needle. I need to place some counter traction so that I can externalize the needle. You can come straight out of the sclera or peripheral cornea. You only need 1 paracentesis or incision to go through. This is for the Siepser type knot, but this is going to be a 4th row pupilloplasty. So similar to Siepser, after you externalize the needle, use a hook to grasp the distal suture, pull it out your incision, then you pass 4 loops of suture, tie it down, and it should stay. That's that pupil coming down. Now, there's a peripheral opening, peripheral to where I'm suturing, and it almost looks like an iridotomy. And I was thinking about closing this and then using the vitrector to create an iridotomy, or just leaving this as the iridotomy to prevent pupillary block. So I'm considering that, but I'm watching everything right now. I'm going to remove the trocar first, massage it, see if it will seal. And I'm noticing that there's a leak. I'm going to hydrate all my corneal incisions. I'm going to seal the eye as much as I can. But as I'm injecting fluid in the eye, I'm seeing that part of the conjunctiva balloon up. So I need to address that. I need to seal it. There are a lot of incisions. I just need to make sure they're all sealed. It's very important, even if there's a tiny leak, to suture the sclera. Otherwise, you can have postoperative hypotony and choroidal effusions, and then you'll have to go back to the OR and suture it. So now that it's ballooned up, it's kind of hard to see exactly where the opening is. So what I do is I put irrigation in the eye, and then I can see it exactly where it's coming out. There's a little dark shadow of the sclerotomy, and I see exactly where it's ballooning out. And so then I get a atovicral suture, and I pass it right through that sclerotomy to close it. This is a dissolvable suture. It's atovicral. I think they dissolve typically in 4 to 8 weeks, but they can be a bit irritating for patients. So sometimes after a few weeks, you can remove it, but don't remove it too early because then you'll get a post-op leak and hypotony. You don't want that. Now look at that iridotomy. Isn't it looking really small? I'm going to perform IA with the vitrector just to remove as much of the debris and viscoelastic as possible. But that iridotomy is looking small, so I think I'm not going to put another suture in it, because then if I do that, I would have to create another opening in the iris anyway with the vitrector if I close that. Here I'm ensuring all the incisions are watertight. The eye is watertight, it's sealed. There's no ballooning of the conj where the sclerotomy is. I'm checking the haptics to make sure that they are buried, and it looks great. Fortunately, the patient did wonderful. And that's it. IOL exchange after about 35 years. The patient was legally blind before and now can see 20/50 uncorrected. I hope you found this video helpful. Thank you so much for your attention. I appreciate you watching as always. I'll see you on the next one. Peace.